Daddy!
Ma, sabihin ni Papa, oh.
Miss ka na namin, Papa.
Parang kailan lang. Nung nag-aaral pa ako, lagi kang nasa tabi ko. Kahit napagod ka, pipilitin mo pa rin akong tulungan. Kahit abutin tayo ng umaga. Natuto ako sa mga aral na paulit-ulit yung sinasabi at pinapaalala. Kahit minsan, nakakasawa. Pero ma, pa, tama pala kayo. Kaya kong tumayo sa sarili kong mga paa. Matapang na harapin ang mga pagsubok sa buhay. Nang dahil sa paggabay niyo. Alam ko, lagi niyo pa rin akong binabantayan. Ma, pa, salamat sa lahat.
Paghandaan ang iyong kinabukasan, paghandaan ang panahon ng pangangailangan. Pag may St. Peter Life na manatag ang kalooban, may St. Peter Chapels pang masasandigan. Kahit saan, kahit kailan maasahan, bawat pamilya dapat may St. Peter Life na. St. Peter Life na.
I want this to be perfect. Dapat maluwag para lahat ng ka-close ko makapunta. Mga 80 people? Pwedeng purple flowers. Favorite ko yun eh. It will be my last day. You're right ko, sosyal ah.
Yes, ma'am. Pwede po lahat yan.
Souvenirs kaya? Yung kabahan ko pwedeng kulay pink?
Ang cute niyo ah, ito ah. Paborito ko ni Daddy.
Ma, pizza ni Papa. Oh.
Miss ka na namin, Papa.
Parang kailan lang. Nung nag-aaral pa ako, lagi kang nasa tabi ko. Kahit napagod ka, pipilitin mo pa rin akong tulungan. Kahit abutin tayo ng umaga. Natuto ako sa mga aral na paulit-ulit yung sinasabi at pinapaalala. Kahit minsan, nakakasawa. Pero ma, pa, tama pala kayo. Kaya kong tumayo sa sarili kong mga paa. Matapang na harapin ang mga pagsubuhay. Nang dahil sa paggabay niyo, alam ko, lagi niyo pa rin akong binabantayan. Ma, pa, salamat sa lahat.
Paghandaan ang iyong kinabukasan, paghandaan ang panahon ng pangangailangan. Pag may St. Peter Lifeline, manatag ang kalooban. May St. Peter Chapels pang masasandigan. Kahit saan, kahit kailan maasahan, bawat pamilya dapat may St. Peter Lifeline. St. Peter Lifeline.
I want this to be perfect. Dapat maluwag para lahat naka-close ko makapunta. Mga 80 people? Pwedeng purple flowers. Favorite ko yun eh. It will be my last day. You right ko sosyal ah.
Yes, ma'am. Pwede po lahat yan.
Souvenirs kaya? Yung kabahan ko pwedeng kulay pink?
Ang kulit niyo ito ah. Paborito ko ni Daddy.
Ma, it's me ni Papa. Oh.
Miss ka na namin, Papa.
Parang kailan lang, pa ako, lagi kang nasa tabi ko. Kahit napagod ka, pipilitin mo pa rin akong tulungan. Kahit abutin tayo ng umaga. Natuto ako sa mga aral na paulit-ulit yung sinasabi at pinapaalala. Kahit minsan, nakakasawa. Pero ma, pa, tama pala kayo. Kaya kong tumayo sa sarili kong mga paa. Matapang na harapin ang mga pagsubok sa buhay. Nang dahil sa paggabay niyo. Alam ko, lagi niyo pa rin akong binabantayan. Ma, pa, salamat sa lahat.
Paghandaan ang iyong kinabukasan, paghandaan ang panahon ng pangangailangan. Pag may St. Peter Lifeline, manatag ang kalooban. May St. Peter Chapels pang masasandigan. Kahit saan, kahit kailan maasahan, bawat pamilya dapat may St. Peter Lifeline. St. Peter Lifeline.
I want this to be perfect. Dapat maluwag para lahat ng ka-close ko makapunta. Mga 80 people? Pwedeng purple flowers. Favorite ko yun eh. It will be my last day. Yung ride ko social ah.
Yes, ma'am. Pwede po lahat yan.
Souvenirs kaya? Yung kabahan ko pwedeng kulay pink?
Mga kababayan, ang pambansang awit ng Pilipinas.
Sama I see a new revival, steering as we pray and sing. We're on our knees, we're on our knees. Hosanna, Hosanna, Hosanna in the highest. Hosanna, Hosanna, Hosanna in the highest. Hosanna in the highest. Hosanna in the
Hello and welcome everyone. Thank you for joining us in today's webinar, the first in a series of online webinars on DeathCare, of course in celebration of the 2020 St. Peter DeathCare Week. My name is Rona Lucas Gianshand, Assistant Vice President for Marketing, Research and Development of St. Peter Life Plan, and I will be your host and moderator this afternoon. Our topic for today is caring for the sick and the dying. We are blessed to have with us a palliative care specialist. But before I introduce to you our distinguished guest speaker, I would like to remind everyone that you may comment your questions below and we will try our best to answer all your questions during the Q&A after the presentation. Okay, so our guest speaker for today is the head of Supportive Oncology and Palliative Care section of the Augusto P. Sarmiento Cancer Institute of the Medical City, or TIGAS. She is also a faculty and assistant professor of the Institute of Medicine of FEU Nicanor Reyes Medical Foundation and is a lecturer at the Ateneo School of Medicine and Public Health. She finished her fellowship training in supportive, palliative, and hospice care from the UPPGH and finished her Master's of Science in Epidemiology from the College of Public Health in UP Manila. She is also a contributing author in the textbook of Family Medicine by the Philippine Academy of Family Physicians. She is a founding member and board of trustees of the Philippine Society of Hospice and Palliative Medicine, a fellow of the Philippine Academy of Family Physicians, a specialty board of examiner of the Philippine Academy of Family Physicians from 2007 to 2010, an interviewee in the 2015 Quality of Death Index, ranking palliative care across the world, and also a fellow of the Salzburg Global Seminar in December 2016 on the session on rethinking care towards the end of life. Now, without further ado, ladies and gentlemen, please join me in welcoming Dr. Maria Fidelis Manalo.
Good afternoon, everyone. I have been invited to share with you what we know about the care of persons in the critical and terminal phases of life. So this will be the flow of our discussion this afternoon. In the first place, I'll give you a definition of what end-of-life care is all about, talk about Kubler-Ross 5 stages of grief, what to expect when the patient is dying, the signs of approaching death, the role of the family, palliative and hospice care, symptomatic management, signs of clinical death, and how to cope with death. So we're familiar with the life cycle of a human being. We all came from a fertilized egg from our parents. We became fetuses, babies, children, teenagers, adults, old age. And if there's one thing that's sure to occur in everybody who's here on earth, it's the fact that we will all die. And it did not be a death with so much suffering and pain. So when we talk about end-of-life care, normally the ones who are tasked to do that would be doctors and nurses. And ultimately, what they hope to provide the patients would be physical comfort and psychological peace in the final phase of life. I don't know if you're familiar with the Kubler-Ross 5 stages of grief. What the psychiatrist Kubler-Ross, who was also a very good palliative care practitioner, said is that anybody who has been diagnosed with a serious illness, and definitely if it's a life-threatening illness, a terminal illness, for example, advanced cancer, will go through some emotional upheaval in his or her life. So the most common reaction when a patient goes to the doctor and then the biopsy results come out and it says there that the patient has cancer and it's just an ordinary cancer, but it's already spread to the different organs, is to actually experience denial. And this is manifested in avoidance, confusion, shock, and fear. Then later on, after the period of denial, it's possible that the patient will experience anger, manifested as feelings of frustration, irritation, and anxiety. So they could be having bursts of temper, or they cannot sleep, they cannot eat because of all these negative emotions that's running in his mind and in his heart. And then later on, the lowest point in the stage of grief will be that of depression. At this point in time, when we talk about depression in relation to a diagnosis of a life-limiting disease, it's not necessarily the major clinical depression that we see in people with mental health issues. This depression is relatively appropriate to the diagnosis of such a serious illness. So it's more of a feeling of being overwhelmed, helpless, in fact, even hostile, and if at all possible, to flee from the reality of such a serious diagnosis. And then usually after they get to come to terms with what is happening to them, they start bargaining. And most of the time, they start bargaining with God. So they struggle to find meaning in the diagnosis, even in the terminal illness and eventual demise. No? And of course, they at this point in time, they already try to reach out to the others. They look for support groups, for example, ask the sufferers of the same disease how they are coping, and they're okay with telling their own stories to family and friends. Then hopefully, for all our patients, we help them eventually come to terms with their disease and the possibility of dying from their disease. And this is already the period of acceptance. They are exploring options. They have come up with a new plan in place. And more or less, they move on. No? They don't anymore stay too low, and they already start regaining their peace and serenity. So for all of us who could be taking care of somebody who's so seriously ill to the point that they could be already living in the last months and years of their lives, what is it that we can expect when they are at this point in time in their illness, when they're in fact dying? So don't be surprised if your loved one or patients would be experiencing social withdrawal. This is relatively normal. They become less concerned about their surroundings. They start separating themselves from the world. It's not unusual that they don't want anymore to want to watch the news or to read the newspaper. They don't like people visiting them, even their children, their grandchildren, and even their loved ones. They want to just stay in their room and keep themselves there, hiding themselves from the world. And with this withdrawal comes less of a need to communicate with others, even with close family members. So, as I said, at this point in time, be very understanding and patient, and don't let these create gaps and conflicts between you and the sick person. Now, as far as food is concerned, normally family members are very, very worried when the sick person is no longer having the appetite or the desire to eat. No? But in reality, that's how the body prepares to eventually pass on. There is a gradual decrease in interest in eating and appetite, even for their favorite foods. What usually happens is that the family members go all over the place, buying their favorite food, cooking their favorite food, and yet they will just take a spoonful or so, and then they will stop eating already. No? So sometimes they like to eat, sometimes they don't like to eat. But don't worry, because at this point in time, it's not as if our patients are starving themselves to death. No? This is a reflection more that the disease is actually progressing. And between liquids and solids, they find it easier to just drink juices, for example, and even water, mineral water. But for us who are helping them, since they prefer to drink liquids, we give them oral nutritional supplements that are complete in carbohydrates, fats, and proteins, and they come in liquid form so that they don't actually become malnourished. But one thing here is that don't make this such an issue that you quarrel about it and you actually force them to eat, because if you force feed them, they might choke on the food and you might cause more trouble because they will have aspiration and aspiration pneumonia. Now, it's also part of the fact that the patients could be experiencing in the last months, days of life, that they are sleeping more. It's very difficult for them to keep their eyes open. This is a result of a change in the body's metabolism as a result of their disease. So you have to be very smart and make sure you're around when they're awake and alert. And unfortunately, sometimes they are awake when everybody else is sleeping in the middle of the night. The patient could also be experiencing some form of disorientation and confusion. They don't anymore know the time, the place, and even the names of the people taking care of them, including their spouses and their children. So don't feel offended. In fact, they may even see people who are no longer there, including their dead loved ones. Usually they start seeing their dead parents, their dead brothers and sisters, no? And sometimes patients describe welcoming or beckoning. They would really tell you that tinatawag na siya or sinusundok na siya. So, of course, for family members, they find it so scary to hear patients talk that way. But that's what they're experiencing, and they're letting us know what they actually seemingly see, even if we don't see those illusions. No? While the patient may not be depressed, definitely this is very depressing to family members and even to the healthcare professionals. More than being depressed, we get scared. So what we need to do is to gently orient the patient. If they ask, where am I? And you say they could be in their house, in their room, or in the hospital. But there should be no need to correct the patient if the patient is not distressed. Because if you keep correcting the patient that she's wrong in your name, for example, then let it be. The patient could also be experiencing some form of restlessness. They start pulling at the bed linens, their clothes, their IV lines, like that. No? So, of course, if it's their IV lines that they start pulling, you'll be worried because there will be some blood coming out of their IV lines. No? But that's all right. So you need to talk to them calmly and assure them. And as much as possible, don't put your face close to their face, because you might startle or frighten them. Again, these symptoms are also a change in the body's metabolism. If the patient is in danger of falling, for example, or harming themselves because they remove the tubes attached to them, then we might prescribe some sedating drugs so that the patient will sleep and rest. Their senses could be affected so that the clarity of hearing and vision may decrease. So the way to do this is to make sure that the room lights are soft, prefer yellow lights, not to prevent visual misinterpretations. And never assume that the patient cannot hear you, as hearing is the last of the 5 senses to be lost. In fact, this is one of the things we teach family members that you don't talk about things you don't want them to hear, or you talk about things that they would like to hear. Yung sinasabi natin na bulungan mo siya para marinig ka niya. No? So, and normally, part of the things na binubulong natin sa may sakit is some form of prayer, some form of consolation and comfort. They could be experiencing some problems with urination and bowel movements, no? But this is usually seen when death is quite near. So we actually invite family members to participate in the direct care. The nurse or the caregiver can help place absorbent pads under the patient for more comfort and cleanliness, or if necessary, you might need to insert Foley catheters. And don't be surprised that as the patient is nearing the end of life, the amount of urine will start decreasing and the urine will become darker. It's more concentrated and more pungent smelling. So the following are the signs of approaching death. If you notice, there will practically be changes from the top of your head down to your toes. No? And I will go over them one by one just for you to realize if our sick person is already near dying. So I apologize for the not so pleasant images, but that's the way it could happen at times, that there will be some changes in the facial appearance, no, because they have not been eating for months and weeks, so they're practically skin and bones, so humpak na yung mukha, syempre nag-worry na yung family members, no, na parang ang payat-payat na niya, kita na nila yung buto, no, lalo na when they're changing the clothes of the sick person, no, so there will be some changes in the face and in the body of the patient. And as I mentioned already, there will be changes in the sight, speech, and hearing. Now, the breathing pattern of the patients will also change. At the beginning, the body will detect that there's not much oxygen going on to the blood and to the different vital organs. So the patient will start breathing quite fast. So, of course, for family members, they get distressed about this because you look like as if you're panting, as if tumakbo ng malayo, pero nasa bed lang naman yung pasyente. So, hingal na hingal yung pasyente. But that's just an ordinary coping mechanism of the body with the fact that there's lesser oxygen being circulated. Then later on, as they near end of life, the breathing pattern actually will become less and become irregular to the point that as if they're no longer breathing, and we call that situation an apnea. But sometimes they recover. No? So you will note that the patient will stop breathing for a few seconds, and then they will breathe again. So the respiratory rate is lower and irregular. The blood pressure also at the beginning could go up, again, as a compensatory measure to deliver more oxygen to the vital organs. But later on, as death is drawing near, it will become lower, and the pulse may initially increase and then later on decrease. So if you notice, the way the body copes with dying is that at the beginning, everything is high. Breathing rate is high, pulse rate is high, blood pressure is high. Then the nearer they are to death, then the blood pressure goes down, the pulse rate goes down, the respiratory rate or the breathing rate goes down. Okay? The arms and the legs may become cold to the touch. The hands and feet become purplish. The knees, ankles, and elbows are blotchy. And all of these are symptoms of less blood supply to the arms and the legs. No? Because the blood is being rechanneled to the vital organs like the heart, the brain, the kidneys. No, so there are some changes also in the gastrointestinal system. That's the reason why they also don't want to eat. Since, as I mentioned, the blood will be rechanneled to the vital organs, the brain, the heart, the kidneys. Our stomach and our intestines get less blood supply. So that's the reason why we advised you not to force feed terminally ill patients and dying patients. Because if you force feed, so the food will remain in their stomach, so it's going to just expand and cause pain and bloatedness, and then If there's too much food already in the stomach, then the food will go back to the esophagus, and then that's what we call, they might aspirate and have aspiration pneumonia. So babalik yung kinain niya, so pwede pa siyang magsuka tuloy. No? So wag nating pipiliting kumain, yung lalo na yung pagmalapit na talagang mag-expire yung pasyente natin. Okay? And then, there's one sign that we say is pathognomonic of dying. Ibig sabihin, when the doctors and nurses hear this, what we call a death rattle, it's a rattling sound. It's because the patient is no longer able, or they are too weak to clear their throat or cough. No? So, it could be very loud, but it just comes and goes. But normally, when we hear this death rattle, more or less, we know that the patient might be dying in the next 3 days. No? So it's really pathognomonic of dying. No? So in other words, malapit na talaga mag-expire yung pasyente pag naririnig natin maingay na yung paghinga niya. Okay? Hindi na siya makaubo. She cannot clear her throat anymore. Now, there will be changes also in their genitourinary system. So, I mentioned already na nababawasan na yung pag-ihik nila. So, hindi na din tayo madalas mag-change ng diaper, which is good kasi nga at least kung hindi tayo palit ng diaper, hindi natin sila masyadong ginagalaw. So, mas komportable sila pag hindi natin sila masyadong ginagalaw. And then, the body temperature can also fluctuate. Fever might be experienced by the patient. There could be increased perspiration, often with clamminess. Yun yung medyo nagugulat yung mga pamilya, no? Pawis na pawis, pero malamig. So, yung tinatawag nating nanglalamig sa pawis, no? So, those are some of the changes also in body temperature. The skin color changes. If the patient has fever, then namumula-mula yung pasyente, or kung nilalamig naman, nangingitim. No? They're bluish with the cold. And then, usually, pag talagang malapit na, the patient will suddenly turn a pale yellowish color. Pale yellowish color, which is quite different from what we call jaundice, yung mga may hepatitis na dinilaw, ibang klase yon sa paninilaw nung malapit nang mag-expire ng mga pasyente. They look pale, and at the same time, they look yellow. Okay, and then, of course, the brain, there will be some changes also in the brain and the spinal cord. The patient will enter into a coma before death and not respond to voices when you call them or even when you touch them. For example, for us doctors, we check how responsive they are by deliberately inflicting some form of pain. So, pero minsan kahit na kurutin mo pa siya, hindi na niya nararamdaman na kinukurot mo siya. O kaya naman we're inserting IV lines, even if we're already stopping them with needles, hindi nila na nararamdaman na tinutusukan na kanila natin sila. Okay? So, and this is somehow a blessing in disguise. Kasi nga, for many of our patients, ang request lang nila sa amin, Doc, gusto ko, Sarah, parang natutulog lang ako. So, in a sense, when you say a patient is into coma, that's a deep sense of unconsciousness. No? So, hindi na sila gumigising. Tulog na tulog. Sobrang lalim ng tulog na hindi na nga gumigising halos. Pero, syempre, humihinga pa sila. Kahit na anong tawag mo, kahit na inaalog-alog mo sila, hindi sila masyadong gumigising. Okay. So we already identified some of the things that you might be able to see in somebody reaching the terminal stages of their illness. And for this, we call on the family a lot to help us take care of the dying patient. And there's also a specialty of medicine, which we call palliative and hospice care, who have been trained to really take care of those with serious life-limiting illnesses. So, we always say that the most important person who should be around, who should be surrounding the patient, who should be accompanying the patient, will always be the family. Okay? So, Pope Francis actually said that the family's presence sustains the patient, and their love represents an essential therapeutic factor in the care of the sick. It is the father, the mother, brothers, sisters, and godparents who guarantee care and help the person to heal. Okay, so importante nandiyan ang family members. Kaya nga kami, since our field is really palliative care, we always ask the family members kung meron ba tayong mga kamag-anak na nasa abroad, na baka gusto nilang umuwi at dumalaw. Sana naman, wag nating ipagpaliban yung pagdalaw sa may sakit, lalo na nga kung medyo serious yung karamdaman, kung kailan hindi na nila tayo nakikilala o kaya naman comatose na sila, medyo nahuli na tayo pagka ganon. It's much better if the immediate family members who are from abroad manage to have an emergency leave from work and try to visit their sick mother or father, brother or sister, while they're still able to interact with them. It is essential that the sick under care do not feel themselves to be a burden, but can sense the intimacy and support of their loved ones. I think lahat naman tayo, ayaw nating maging pabigat kahit kanino. Kaya nga kahit may sakit na sila, they try their best to be taking care of themselves. Pero syempre, darating sila sa point na bedridden na sila, hindi na nila kayang kumain mag-isa, tumayo mag-isa, pumunta sa toilet ng mag-isa. So, kailangan na nila ang membro ng pamilya para tulungan sila. So, hopefully, hindi nila maramdaman na pagod na tayo sa kaaalaga sa kanila. And then for hospitals and other healthcare facilities, we should not neglect, but rather integrate the family's human and spiritual accompaniment in a unified program of care for the sick person. So in other words, we really involve the family members in the care of the sick and the dying. So let me tell you a bit about what we do in palliative care. So palliative care is a subspecialization. By training, I underwent family medicine residency, and that's about 3 years after our graduation and passing from medical school. And then we go through another year for a fellowship training in supportive palliative and hospice care. So dito sa Pilipinas, ang nagpanimula ng training na yon sa UPPGH. So what is it exactly that we do, and how do we help terminally ill patients? Palliative care is actually an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses. And what do? We try our best to prevent and relieve suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So in other words, hindi lang yung physical pain yung inaayos natin. So pagka first time pa lang akong makikilala ng mga pasyente at ng pamilya, syempre, yan ang palaging tanong nila, Dok, ano ba yung palliative care? Para lang madaling maintindihan, ang una kong sasabihin, ano po, ang kadalasan ko pong ginagawa, pain management. Pero bukod po sa pain management, tinatry ko rin po kayong tulungan sa iba pang sintomas na nagpapahirap sa inyo, pati na rin yung mga psychosocial problems natin, at saka yung mga spiritual problems, like yung mga feeling lost, feeling hopeless, feeling helpless, nalulungkot, nag-worry. Yan yung mga bagay na tinutulungan natin ng pasyente, pati na rin ng pamilya. Okay? So our goal is to anticipate, prevent, and reduce suffering, and to support the best possible quality of life for patients, families, and caregivers, regardless of the stage of the disease or the need for other therapies. So huwag po tayong magkakamali na sasabihin na ang pang-palliative care para lang sa mga mamamatay na o yung mga may taling na sa buhay. No, because what we're supposed to help you with is to improve your quality of life. So kahit bagong diagnose pa lang po kayo ng meron po kayong advanced cancer, stage 4 po, magagamutan pa tayo, magpapa-opera pa kayo, magki-chemotherapy pa kayo, magre-radiotherapy pa kayo, okay lang yon na your attending physician will already refer you and your family to us, no? Because what we want is to help you go through your treatment successfully, because we help you control the side effect of your treatments. Kasi after surgery, hinang-hina, hindi makakain, hindi makatulog, ganun din after chemotherapy, radiotherapy. So marami pa tayong pwedeng gawin para mas maganda yung pakiramdam nyo before, during, and after your treatments. No? So tulong-tulong kami mga doktor para mas maganda yung quality of life ninyo. So hindi necessary na dapat stage 4 kayo bago kayo ma-refer sa palliative care. Okay? At saka hindi ibig sabihin nun na pag na-refer kayo sa palliative care, titigil na yung ibang gamutan. Hindi na kayo magpapa-opera. hindi na kayo magki-chemotherapy, hindi na kayo magre-radiotherapy. Actually, pwedeng sabay-sabay lahat yan. Nandiyan yung radiotherapy, chemotherapy, surgery, at palliative care. Pati na din yung mga ibang specialista na kailangan natin to help you and your family have a better quality of life as you go through such a roller coaster ride of having been diagnosed with a big C, for example. Sorry. Sorry. Okay, so in palliative care, we talk about what we call total pain control. Kasi nga usually, pag sinasabing a patient is in pain, syempre ang una agad natin iisipin, physical pain, no? Which can actually be multiple. So, lahat masakit pag tinanong mo yung pasyente, no? But aside from the physical pain, the patient could be suffering from anxiety, anger, and depression. We already mentioned this, no? From the Kubler-Ross 5 stages of grief. They could also be having some interpersonal problems, no, including loneliness, financial stress, and family tensions. Lalo na kung halimbawa hindi na makapagtrabaho yung may sakit. Tapos, syempre, magastos magpagamot. So, kailangan may ibang taong tumulong para masustentuhan ang gamutan. No? So, nakakadagdag pa yon sa iniisip ng may sakit. And then, of course, we already mentioned it, that it's possible that the patient is not yet at the level of acceptance na medyo malapit na nga. No? So, they are feeling hopeless and there's a desperate search for meaning. Siyempre, ang una nilang tanong, Dok, bakit ba ako nagkaganyan? Health buff naman ako, kumakain naman ako ng tama, hindi naman ako naninigarilyo, hindi naman ako umiinom ng alak, lagi naman ako nagpapa-check up sa mga doktor, natutulog ako ng maaga, kumpleto yung tulog ko, hindi naman ako nagpapaka-stress, bakit nagkasakit pa rin ako? No? So, they're really searching for the meaning of how come they got sick. No? Sabihin nila, wala naman silang lahi ng cancer, for example. No? So, kailangan naming tulungan sila through counseling to discover the meaning of their pain and their suffering and their illness and even their dying. Okay? At ito nga yung pinakamahirap gamutin. So in fact, hindi ito nakukuha ng bibigyan lang namin kayo ng medications. We really have to subject the patient to counseling. Okay, and what is the role of hospice care in the care of the dying? No? So actually, hospice care is still under palliative care. Pero we make a distinction when you see the patient is already under hospice care, the doctors have already prognosticated and told the patient and the family that more or less the patient might have 6 months or less to live. So, and when a patient is going to receive hospice care, it can be given at home, in the hospital, or in a hospice. Here in the Philippines, we don't have many hospices yet. No? So, most of the time, ang choice ng pasyente, either aalagaan sila ng pamilya sa bahay, o kaya naman magpapa-admit sila sa ospital. Okay? So, terminally ill patients are accompanied with qualified medical, psychological, and spiritual support so that they can live with dignity, comforted by the closest of loved ones in the final phase of their earthly life. Hospice centers should be places where the therapy of dignity is practiced with commitment, thus nurturing love and respect for life. So in other words, we want patients in hospice to already go through a peaceful and hopefully pain-free dying process, a death with dignity. That's why we say it's a therapy of dignity. So hindi ba yung ang dami-daming nakakabit sa katawan na parang Christmas tree na puro may tubes sa lahat ng butas ng katawan. So hindi mo na tuloy makilala yung pasyente, manas na, puro tusok, no? So that's not how we would want our dying patients to look and to experience. So that's why we say we want that they live with dignity in the company of their loved ones in the final phase of their earthly life. Now, what is an advance directive? In our institution, the medical city, we try our best to make it a point to talk to patients who have been diagnosed with serious illnesses to already start thinking and discussing with their doctors and with their family members what we call their advance directives. What are these? These are written documents that contains instructions that consent or refuse specified medical treatment. So for example, sasabihin ng pasyente, ako doc, pag malapit na ako, gusto ko peaceful lang. Gusto ko sa bahay lang. Gusto ko pain-free lang. Huwag mo na akong kabitan ng kung ano-ano dyan. So ibig sabihin nun, sinasabi ng kagad sa akin ng pasyente na ayaw na niyang magpatubo. We call that endotracheal intubation at kakabit namin siya sa mechanical ventilator. Sasabihin ng mga pasyente, Dok, ayoko noon. Yung kakabitan mo pa ako ng tubo at ikakabit mo pa ako sa medical ventilator, mechanical ventilator. O kaya naman sasabihin nila, Dok, wag mo na akong i-resuscitate. Kaya usually, the doctors will put that in the chart as do not resuscitate, do not intubate. No? Or another term for it is to allow natural death, meaning when it's time to go, it's time to go. Gusto lang natin peaceful yung pasyente. Okay? So, the advantage of the patient discussing advance directives with the doctors, with all his doctors, and with his family members is that it clearly states their goals and preferences for care. Halimbawa, gusto nila sa bahay na lang sila. No? So, at least alam natin lahat na yun pala yung kagustuhan ng pasyente. So, normally, mas maganda pag-usapan to, yung malakas pa yung pasyente, yung malino pa yung isip, para hindi siya natatakot. Kasi, kumbaga para sa kanya, malayo pa naman yan. So, mas maganda ng paghandaan. No? So, wag nating hintayin na hindi na makausap yung pasyente, wala na siya sa tamang pag-iisip, tsaka natin siya tatanong kung anong gusto niya. No? So, pagka ganon, we will have to rely on the help of family members to tell us what they think the patient would want. Pero ang hirap, pag ang pasyente walang advance directives, minsan nag-aaway-away yung buong pamilya, hindi sila magkasundo-sundo. May ibang mga anak, gusto tubuhan. May ibang anak, ayaw. May ibang anak, gusto ipa-CPR. Yung mga ibang anak, ayaw naman. So nagkakagalit-galit tuloy sila at the end of life, imbis na peaceful na lang yung pasyente, peaceful na lang din yung relatives, no? Kaya nga, it's a personal advocacy of mine to really, when you have a serious illness that is potentially life-threatening, that you already start discussing advance directives with your spouse, with your children, with your grandchildren, with your brothers and sisters, with your doctors definitely, para alam namin lahat kung ano yung gusto mo. In other words, susundin namin yung gusto mo. At lagi kong sinasabi sa buong pamilya, no, kung sinulat na ng pasyente yung gusto niya, obviously, irerespeto natin lahat yon. Hindi po pwedeng pag hindi na nakakapagsalita, hindi na gumigising ng pasyente, then babaliwalain natin yung advance directives nila. That's unfair. In fact, it's unethical even. Kasi nga, sinabi na nga niya sa atin yung gusto niya, tapos porque lang hindi siya makareklamo, then hindi na natin susundin. So, the advance directives is meant to be respected and implemented by the doctors, the healthcare team, the family members, the relatives. Paalala lang po ito, no, na yun yung huling habilin at huling gusto ng ating pasyente. Kaya po dapat pakinggan natin sila at huwag nating i-disregard ng basta-basta. No? Usually po, gina-guide naman namin kayo kung paano gawin ng advance directives at how to bring it about also. Okay. So how do we actually take care of the dying patient? So we provide psychological support. We talked about advanced planning. Of course, there are some financial concerns. We always say na usually dapat meron ng special power of attorney ang immediate family members so that they can also transact with the bank and things like that, no? There could be some legal and ethical concerns. We help the patient transition to home, for example, or to death. Definitely, part and parcel of that would be an effective pain management, which we do a lot. And definitely, we make the patients as partners. In Medical City, we say patients are partners. So, hindi po pwedeng itago ang katotohanan, even the fact that the patient is dying from the patient. Ang lagi po natin sinasabi, minsan lang po tayo mamamatay. No, walang repeat performance. So we don't die twice. So syempre we want to die the best possible way. So the only way to do that is kung makapaghanda tayo. So that's why the doctors have to tell the patient the truth, that they have a poor prognosis, and that they are actually entering the last months, weeks, or days of life. No? The patient has the right to information. Siya po yung may katawan, it's her own life, and it's its own death that we're talking about. And of course, we provide symptomatic management of any distressing symptoms at the end of life. So, kung iisipin nyo po, ang dami po palang ginagawa at the end of life. Kaya po kaming palliative care, marami din po kaming panahon na nilalaan sa bawat isang pasyenteng inaalagaan namin. Kasi we're not just going to take care of the dying patient, we're also going to take care of the family of the dying patient. Okay? So, you will never hear us say that there is nothing more that can be done. Yung minsan naririnig po ng mga pamilya na wala na po tayong magagawa. Hindi po manggagaling sa amin yan. There is always something that can be done, even if it's simply to sit beside the patient and hold her hand and offer a few words of comfort and solidarity. No? So, tender loving care po ang kailangan ng dying. No? So, kahit na maybe we are going to stop aggressive medical management, pero there will always be comfort measures that we can institute so that the patient will feel accompanied and cared for. Okay. So, palliative care includes psychosocial support and spiritual care. So, pag sinabi sa akin ng pasyente, Dok, wala na po ba talaga akong pag-asa? Actually, syempre, pagka sinasabi sa akin yun ng pasyente, I don't get used to it. Kahit pa paano, feeling mo, gusto mo na din umiyak. Syempre, pag sinabi ng pasyente yun na, Dok, wala na po ba talaga akong pag-asa? Lalo na, pag matagal ko nang inaalagaan yung pasyente yun, syempre, nagiging close na din kami sa pasyente, pati sa pamilya nila. Pero you know what? Hindi lang siya parang pampalubag loob when we say na huwag po tayong mawawala ng pag-asa because it's the truth. We should never lose our hope, our faith, and our love. No? Those three things should remain no matter how seriously ill the patient might be. So lagi natin silang bibigyan ng pag-asa. Hindi natin sila lulukohin, hindi natin sila bibigyan ng false hope na sasabihin natin, hindi, mahaba pang buhay mo. Aabutin mo pa yung Christmas, aabutin mo pa yung graduation ng anak natin, o magpupunta pa tayo sa abroad. Pero alam naman natin lahat na hindi mangyayari yon, di ba? So, huwag tayong maniling lang ng pasyente kasi kawawa naman sila pag hindi natin sila sinasabi yung katotohanan. We really foster hope, but it has to be a realistic hope. No? Then as I said, let's provide comfort. Let's assure them of the presence of their loved ones, of the community. No? So, kaya nga maganda na binibisita sila ng mga pamilya, kamag-anak, mga kaibigan, katrabaho, no? Mga kabarkada, maganda yon. And then as I said, we help them find meaning in their pain and in their suffering. Talagang yan ang number one tanong nila sa akin eh, Dok, ano kaya ang ibig sabihin ng lahat ng ito? Tapos bago pa ako makapagsalita, sasagutin na din nila yung tanong nila sa akin. Sabi nila, Dok, alam ko na po. Tapos sabi ko, ano nga yun? Sabi niya, kasi Dok, minsan, dahil sa mga nangyayari sa buhay ko, medyo napalayo na ako sa Diyos. Hindi na ako nagdadasal. Hindi na ako nagsisimba. O kaya naman, busy-busy na ako sa trabaho ko, napabayaan ko na yung pamilya ko. O kaya naman, sobrang stress na ako, Dok. Hindi na ako natutulog, hindi na ako kumakain. So, siguro kaya ako nagkasakit para ma-realize ko ano ba talaga importante sa buhay. Tapos, syempre, tatanungin ko, ano nga po ba yung importante pala sa buhay? Di, syempre, sasabihin nila sa akin, di, syempre, Dok, Diyos lang at pamilya. Kahit yung trabaho nga naman, pag may sakit na tayo, hindi na tayo makapagtrabaho. So in the end, they discover the meaning of their pain and suffering in God and in the love of their family members. No? So kaya nga lagi nating sinasabi, parang kumakatok ang Diyos na, hey, napapabayaan mo na ako. No? So halika muna, balik ka muna sa akin. No? So, and it's actually the patients who discover that on their own. No? They find meaning in their pain, in their suffering, and even in their dying. And as I said, we try to maintain the dignity of the patients as much as possible. We limit their fears of abandonment. And if the patients are Catholics and they are admitted in hospitals where there are chapels, then we refer them to chaplains for anointing of the sick, communion, confession. No? So, sa awa ng Diyos, ang babait naman ng mga pare, isang tawag mo lang, pupuntahan na kagad nila yung may sakit, bibigyan na kagad nila ng anointing of the sick. At lagi kong pinapaliwanag sa patient and the family na ang anointing of the sick ay hindi lang sa mamamatay. Binibigay siya sa mga buhay. No? So, in fact, it's a sacrament of healing. Okay? So, wag po tayong matatakot pagka pumunta na si Father para bigyan tayo ng anointing of the sick, communion, at confession. Okay. So, those are from the psychosocial and spiritual point of view. But I already mentioned to you that the patients could be suffering from a lot of distressing symptoms. For example, they could be suffering from some problems from their breathing. And, of course, lagi naming pinapalalahanan ng family members. Make sure you have some oxygen at home para kung sakaling mahirapang huminga, meron na tayo ng tangke ng oxygen na magagamit, no? And all you need to do is to elevate the patient's head and shoulders to make their breathing easier. You keep the room well ventilated and to keep the crowds away. And then kung kinailangan talaga, kailangan na rin bumili ng suction machine and periodic suctioning might be necessary. If the patients have some problems associated with eating and drinking, then we say they could be suffering from anorexia. Ibig sabihin lang ng anorexia, walang ganang kumain. O kaya naman nauseated, nasusuka. No? This is relatively common in dying patients. That's why they are unable to take any form of food. And if they are taken, they are not able to digest. So, lalo lang silang nagkakaproblema, sumasakit lang lalo ang tiyan nila. So, if necessary, you might need to give them IV fluids. Kung sa bahay naman, give them sips of water with a teaspoon. And make sure you clean their mouth very well. So, ano pa rin, we still brush their teeth, make them gargle, then you apply emollients so that their lips will not crack. And kung feeling nyo, baka mamaya malunod niya yung dentures niya, better to remove them and keep them safely. Okay. Now, since the patient loses sight, no, so it's better that the family members, the nurses, the caregivers, before touching the patient, will tell the patient what they are planning to do. No? And then speak only what is appropriate. Avoid whispering anything in the patient's room. Kasi, pag naririnig niya nagbubulong-bulungan tayo, parang iniisip niya, bakit na ba ako pinag-uusapan? Ba't ayaw niya iparinig sa akin yung pinag-uusapan niyo? No? So speak distinctly so the patient may understand what is being done to him. And since eyes are open, nakabukas pero hindi naman na minsan nakakakita, hindi na nakakaaninaw, minsan better na papatakan natin ng mga eye mo, yan, eye drops, no, yung para hindi matuyo ang mata, or even to cover them with a gauze, no? And then make sure that the patient is clean and well-groomed. No? So, walang sama na make-upan natin si mommy, si sister. No? Kasi, para maganda sila at mabango. No? So, ang sarap i-kiss kasi nga, ang bango-bango. No? Tsaka hindi mo kang maputla kung nilalagyan natin ng lipstick. We powder them, you know. They love it when we really give them tender, loving care. No? Cleanliness of the skin, hair, mouth, and cloth. Their clothing have to be maintained, no? So, if at all possible, araw-araw pinapaliguan pa rin ng pasyente o kaya naman kahit man lang punas, even sinashampoo natin ng pasyente regularly para talagang malinis sila, maganda ang pakiramdam nila. Then as I said already, there might be some problems with communication, some form of confusion and withdrawal. Then we be very patient with them, no? And understanding. Okay, so as much as possible, Minsan kasi, gising sila sa gabi, tulog sa araw, so baligtad ang sleep cycle, no? But as much as possible, try not to disturb them when they're sleeping. The visitor should be instructed not to disturb them when the patient is resting. So, actually, lagi namin pinangangaralan na sana nga, yung mga bisita, konti-konti lang, tapos sandali lang sila sa kwarto, unless yung pasyente ang may gusto na magtagal sila at marami ang bumisita sa kanya. We try our best to maintain a calm and quiet environment. Tapos for us doctors, we give them the necessary medications to make sure that they're comfortable. No? If they have fever, pain, vomiting, and other drugs, then we will give that to them. Okay. What are some of the common family concerns, no, that family members bring up with us, no? So they will always ask us if they are in pain. So lagi naming sinasabi sa kanila na sometimes even if they are moaning and groaning, it's not necessarily that they are in pain. We see this more often in those with liver problems, no? Yung may cirrhosis of the liver, liver cancer, liver metastases. The patient is very, very restless, moaning and groaning, but we know for a fact that we are giving them adequate pain medications. So we also have to educate the family members na not to worry because it's part of the disease itself. Or for example, when they are not able to feed the patient, of course, they're worried that we're starving the patient to death. So we will say na, pag humingi ng pagkain, ibigay mo, walang bawal, pwede kainin lahat, dahan-dahan lang para huwag magbilaukan yung pasyente. If they want to drink, anything they like, walang bawal. No? Then, of course, they would ask us what to expect, how will they know that the time is short, should we stay by the bedside? I will say yes. Lalo na pag malapit na talaga, obviously, dapat may duty-duty na rin na kapag-anak. So, hindi iwanan sa caregiver lang o sa nurses. So, dapat laging may family members sa tabi ng pasyente when the patient is already dying, no? Especially in the middle of the night. Even if the patient might be in the ICU, you should be in the waiting area of the ICU so that it will be easy for us to call you if necessary. No? So the person can hear up to the last moment usually, and what are we to do after that? So how do you know? If the death happens at home, how do you know that the patient has actually died? No more vital signs. The patient is no longer breathing and wala nang pulso. Hindi nyo na makapa yung pulso. Minsan, they lose their bowel and bladder continence. So, yung sinasabi ng matatanda na ihina, napadumi na, ganyan. So, and then there's no response to verbal commands or gentle shaking. The eyelids might be slightly open and the eyes are fixed on a certain spot pero hindi na nakakakita. And then the jaw is relaxed and the mouth slightly open. So when this happens, then you inform your doctor and then you also inform the coroner. No? Kasi nga, in other words, yung ating funeral services, hinahanda, malayo pa lang. Hindi yung kung kailan namatay na yung pasyente, tsaka pa lang natin iisipin, ako, wala pa pala tayong lupa, wala pa pala tayong memorial plan. Tapos kung kailan ka grieving, you just want everybody's crying, then you start worrying about those things. No? Those things should have been prepared way ahead. No? So it's just a matter of a phone call away, no, the funeral services, for example. So for doctors and the nurses, these are what we look for. No more pulse, heartbeat, and breathing. We look at the pupils, yung mata. We flash the light and see the pupils fixed and not reacting to light. We do some testing for reflexes and there are no more reflexes. And then yung sinasabi nating rigor mortis, there's stiffening of the body after death. No? So that's why we already position the arms and the legs and then the neck also. We straighten them para hindi makatigasan, no? And then there's also what we call a post-mortem hypostasis. There's a dark red or bluish discoloration due to the settling of the blood. And tayo namang mga naiwanan, how do we cope with the death of our loved ones, no? So it's part of loving the person that we grieve. They were very sad. They were sorrowful at their passing. So allow yourself to grieve by looking at pictures, playing nostalgic music, and reading old letters. Use poem or songs as a way to express how you feel. Use painting or drawing to express your feelings. This is especially true for children who have lost their parents. No, allow them to paint and to draw how they feel. Then, of course, imagine how God would tell you how to cope with the death of your loved ones. No, and funeral ceremonies and rituals help with the grieving process. So, at the end of life, we have your multidisciplinary palliative care team assisting you from the beginning of your cancer diagnosis, for example, all the way to the dying moments. No, so our task is to help see the patient and the family through the physical and emotional stages of a terminal illness, to ease your burden along the way, to walk alongside, not to give orders from above, to be there when symptoms arise, when hard questions have to be faced, when fear and loneliness threaten. Also, it falls on us to make sure that we apply to the care of the seriously ill and the dying the same high standards of clinical analysis and decision-making as are demanded in the care of patients expected to get well. So in other words, we are highly specialized and very competent in the care that we provide the seriously ill and the dying. So how do we come to terms with this whole idea that our loved ones are going to leave us soon? So the one beautiful image to bear in mind will be that of butterflies. It's actually Elizabeth Kubler-Ross, the one who told us about the 5 stages of grief that makes us understand what death and dying is all about. She's a psychiatrist. And she tells us that death is simply a shedding of the physical body, like the butterfly shedding its cocoon. It is a transition to a higher state of consciousness where you can continue to perceive, to understand, to laugh, and to be able to grow. No, so from being an ugly caterpillar, you emerge as beautiful and as colorful as a butterfly, free as a bird, laughing and being free from pain and suffering already. And then, of course, for us who are Christians, we look on death and dying from a very Christian perspective. So you have here an image of a hunter and a deer. There is actually a saint by the name of Saint Jose Maria Escriba who makes us understand what death and dying is all about. Because sometimes we feel that kinukuha na tayo ng Diyos, hindi pa naman tayo ready. So parang ang feeling natin, naku, makarating kaya ako sa langit? In fact, some of my patients will ask me that. And this is what Saint Maria Escriba would tell us about those fears of dying and if we're going to go to heaven or not. He says, God knows best. He's not like a hunter in search of prey. He's like a gardener who cares for the flowers and waters them and protects them. And God only cuts them when they are at the peak of their beauty and richness. God takes souls when they are ripe. So in other words, when it's time for us to go, we are already the most beautiful of the flowers growing in the garden of God. And He already cuts us, not for us to die, but He will pick the most beautiful flower of all, the ripe flower of all, so that He will bring that most beautiful flower of all and put it inside His house. So we're not just in the garden anymore. We're going to be inside God's house where we will beautify His house and we will emit the most beautiful scent. No? So papagandahin natin, papabanguhin natin ang bahay ng Diyos. No? So in the end, when we are Christians, we look on death and dying as something very beautiful, very normal, and at the same time, logically, hindi tayo makakalakting sa langit kung hindi muna tayo mamamatay. No? So, what is important is you rely on the help of your palliative care team and your attending physician, your nurses, your caregiver, and definitely your family members a big, big role to play to make sure that yours is really a peaceful, painful death with dignity. And I would like to thank the, the source of my slides and the content of this presentation. And specifically, I quoted a lot from the letter of the Congregation for the Doctrine of the Faith in a letter that is entitled Samaritanis Bonus, that means the Good Shepherd, which is about the care of persons in the critical and terminal phases of life. This is something that came out from the Vatican just last September 22, 2020. And with that, I end, and if you have some questions, I'm here for clarifications.
Hi, Doc. Thank you very much po for that very informative presentation. I like how you said that in palliative care, what the dying patients need is the family's tender, loving care, no? Personally, I am also taking care of my mom who has had a stroke years back, and I find your talk very helpful in assessing her situation and in providing her the care that she needs now and the care that she will need in the future.
Mhm.
Okay. Mm-mm. So to our audience, I'm sure you have a few questions that you may want to ask. If you can comment your questions down below, and while we are waiting for them to ask questions, I'd like to ask my first question po.
Sure.
Given the pandemic situation, Doc, since visitations to the hospitals are, restricted, how is TMC, or how are you doing palliative and hospice care right now since the start of the pandemic?
Actually, for us in the hospital, everything is normal. It's not even the new normal, it's normal. Meaning the number of patients that we see is practically the same. We have face-to-face consultations, even during the pandemic, with all the necessary masking. So they have to wear their mask. We were not even requiring goggles for them. But the doctors and the nurses are properly uh, prepared to face COVID patients also with the PPEs and everything. But we have opened the possibility of teleconsultation so that for patients who are too weak or too scared to go to the hospital, then they can easily reach us, no? Through teleconsultation. For doctors, it's quite difficult because we have to listen to your heart, your lungs. We have to do some physical examination. So we definitely prefer that you come and visit us in the hospital. But as far as visitors are concerned, there are certain floors that we limit visitors to only one. But now that there's no more restrictions from the government, we are not too strict anymore with visitations. I mean, we're practically back to normal since June. No, at least in Medical City, we have what we call a two-hospital setup, meaning there is a clean hospital part where normal patients can go, and there is a dirty hospital part where the COVID patients are seen. So two different entrances, different wards, even different nurses taking care of you. So there's no danger of contamination and contagion. So to make sure that the patients, the relatives, the doctors and nurses are also safe from COVID.
Okay, that's nice to know. At least alam nating lahat safe tayo sa Medical City. Pwede tayo magpa-check up doon kung kinakailangan.
Sa awa ng
Okay.
Diyos. Oo.
Amen. Since wala pa pong questions from the audience, I'll continue with my own set of questions from your presentation.
Sure.
How do you deal with palliative care patients, Doc, who are non-Christians? Kasi what you were trying to say kanina are for Christian patients. So, psychologically and spiritually, how do you address the needs of non-Christian patients?
Well, as long as they believe in a supreme being, not they may call their God differently. For example, Muslims, maybe they call their God Allah, or the Chinese, for example, some of them may be Taoists, for example, or non-Christian religions in general. Basta't may pinapaniwalaan silang Diyos, then I can still provide spiritual care, di ba? Parang they know that they did not give life to themselves, that there is a higher being, that this is not the end of life for them, they believe in the afterlife, then madaling pag-usapan, di ba? So they still find meaning in their pain and suffering and their death if they believe in a God. Siyempre, ang pinakamahirap sa lahat, yung walang pinapaniwalaang Diyos. Di ba, yung ang paniniwala nila, lahat magtatapos dito lang. So, if you think about it, ano na nga bang saysay ng buhay mo kung matatapos na lang din pala kagad, di ba? So, parang, in a sense, nakakaawa isipin na para sa kanila tapos na ang lahat. Pero syempre, since naniniwala ako na may kaluluwa sila, prepare ko pa rin sila, di ba? To meet God, di ba? So, as much as possible, I try to foster hope. I try to foster love. If they don't want to accept faith, then work on their hope and their love. Because kahit na siguro hindi sila naniniwala sa Diyos, mahal pa rin nila ang pamilya nila. At umaasa pa rin sila. Kahit na yung mga hindi naniniwala, mayroon silang pag-asa. No? So we talk about the things that are more common and easier for them to grasp and understand, and they won't feel offended when you talk to them about that. Ang medyo nga minsan akong nalulungkot, yung mga professed Christians, pero at the end of life, ayaw talaga nilang tanggapin ang kamatayan nila. So, bottom line is, hindi lang sila nagtatampo, galit sila sa Diyos. So, yon yung talagang, naku, kumbaga matigas yung puso, kailangan nating palambutin para matuto silang magpatawad. Parang hirap, di ba ang hirap isipin na patatawarin mo ang Diyos, wala namang kasalanan ng Diyos sa'yo, pero ganun may galit sila sa Diyos, so kailangan ko silang ibalik sa Diyos, no? So, that's why it's not just enough to see them once or twice. It really takes a long time, no? Kaya nga, maganda, maaga ang referral sa amin para hindi ako nagmamadaling gawin lahat yon, no? So, yun. We don't give up on them. Even if we have totally different beliefs and background, we try to talk about things that are common to us. Things that value more. Yun.
Parang nagiging pamilya na rin po kayo. Extended family of the dying patient. Tama po.
Actually, minsan tinatawag ko ng mga anak nilang tita. No, lalo na pagka iniimbitahan nila akong pumunta sa wake. So, pumupunta naman ako sa wake kung hindi naman din mahirap ipahan. Tapos, takbuhan yung mga bata sa akin para talagang favorite tita. No? So, masayang malungkot makita ulit sila. Parang ganyan.
Ang hirap pala po ng trabaho ng isang palliative care specialist, no?
Yes, yes.
We have some questions.
Yes.
Yeah, there are some questions from Facebook. We have a question from Hener Marinas. Does insurance cover palliative care or hospice care?
Actually, we are working on it with DOH. No? This pandemic, we have been so busy meeting with all the big bosses of the DOH so that all doctors, in fact, as early as medical school, will have already exposure training in palliative care so that even if they're general practitioners, they have not gone through residency training and fellowship training, then they can at least take care of the dying very well. So, pero officially, is there already insurance and coverage for palliative care and hospice care? Unfortunately, none. Pero not to worry, because we as doctors are covered by PhilHealth, right? So meaning, you will still get your PhilHealth benefits. Yeah, because I'm a family physician, I'm a specialist in palliative care. So you will get discounts because I am covered because I'm a PhilHealth affiliated doctor. Pero yung services mismo, lalo na yung home care, wala pa. And we're trying our best as a society to work on this. Ang mga HMO, hindi pa rin nila kino-cover. Yung mga private insurances, hindi pa rin. Yon. Yung ang mga nagko-cover ng insurance, yung mga international insurance. Kasi abroad, palliative care is so well known. In the US, in Canada, in Europe, in Australia, it's very much part and parcel of their healthcare. So they cover for palliative care abroad. So if the patient has international healthcare insurance, then they are covered including home care. Yun yung maganda. Siyempre, mahal yung mga ganong klaseng insurance.
Very nice to know, ma'am, na in works na pala yung inclusion of palliative and hospice care sa insurance, no? But you've mentioned na sa ibang countries, very widely parang accepted ang palliative and hospice care. Why do you think,
Yes.
ma'am, that in the Philippines it's not so much known to the Philippines?
Cultural yan. Kasi takot na takot pag-usapan ang death and dying. Tabu. Kahit sa ospital, buti nga in the hospitals where I work in Medical City, most patients are very open to talk about death and dying. But in some other institutions, the family members are at the door of the hospital room, nakabantay na yan. Ang una nila talagang tatanong sa akin, Doc, ano yung palliative care? Ano pong sasabihin nyo sa mami ko, sa daddy ko? Doc, wag mo sasabihin sa kanyang may cancer siya, ha? Doc, wag niyo pong sasabihin sa kanyang mamamatay siya. Doc, madidepress po siya. Bawal po. Kaya tuloy yung attending physician, ilalagay pa niya sa chart ng pasyente, do not disclose diagnosis. Do not disclose prognosis. In other words, pinagbabawalan buong medical team na magsabi ng katotohanan sa pasyente. So yon. So, it's something very cultural na parang akala nila we are bringing death on just by talking about it. At natatakot silang ma-depress ang pasyente just because we want to talk about death and dying.
How do you strike a balance sa ganun, ma'am? Kasi of course, as a doctor, you do have to tell your patient what's going on and kung ano yung health condition niya. So, paano nyo po yun wini-weigh?
Well, unang-una, ang una kong kinakausap, yung pasyente. So in other words, kasi pag inuna kong kausapin ng pamilya at pinagbawalan ako, hindi ko na makakausap yung pasyente, di ba?
Right.
But the person consulting you is actually the patient. Nakasama lang niya yung pamilya niya. So whenever I see patients, I look at the patient, I address myself to the patient, nakikinig lang ang family members. Kasi yung ibang doktor, nasanay na ang unang kinakausap yung pamilya. Okay? So ngayon, kung kaharap ko na yung pasyente, kaharap, at sa kanya ko sasabihin yung katotohanan, hindi naman brutal na, alam mo ba, mami, advanced cancer ka, isang buwan na lang. Hindi ganon, di ba? Kahit naman siguro, tao, kahit ako pa yon sabihin mo sa akin ng ganyan, di ba parang sinampal mo ko, nagulantang ako sa sinabi mo, di ba? So normally, there is a proper way of what we call disclosing bad news. So unang-una, tinatanong muna namin kung ano yung alam nila sa sakit nila. So tapos, depende dun sa sinabi nila sa amin, tatanungin namin, ano po bang pagkakaintindi nyo sa sinabi ng doktor ninyo na may cancer daw po kayo? Tapos manggagaling sa kanila yun, di ba Dok, ang cancer nakakamatay? Then sasabihin ko, well, depende po sa cancer at depende po sa stage ng cancer. Ano po ba ang sabi ng doktor ninyo? Yan. So, in other words, susundan ko lang yung binabanggit ng pasyente, hindi ko siya inuunahan. No? At pinagpapaalam ko kung gusto niyang malaman yung katotohanan tungkol sa sakit niya. So we say, Mami, medyo hindi masyadong maganda yung mga findings natin. No, gusto niyo po bang pag-usapan natin to? Pag sinabi niyang gusto niyang pag-usapan, uulitin ko uli, Mami, paano kung medyo bad news yung pag-uusapan natin? So may idea na sila na hindi maganda yung pag-uusapan. Pero pag sinabi pa rin nila, sige lang Doc, let's talk about it. Then prepared na sila kasi I already mentioned the word bad news eh. Diba? Kumbaga, kahit pa paano, kumbaga, Pin-repair mo muna sila psychologically na hindi maganda yung pag-uusapan natin. Pero pag sinabi ni Kong, halimbawa, Mami, bad news eh. Kasi nga, may biopsy tayo, di ba? Meron tayong mga scans, di ba? Na sinabing, Dok, ayoko pong malaman. Hindi ko pipilitin. Basta sasabihin ko lang, sige lang po, okay lang po yun. Pero sana po pag-isipan nyo, kasi nga po, kailangan natin pag-usapan yung plan of care natin. So, paano ko po papaliwanag sa inyo yung gamutan kung hindi nyo naiintindihan yung sakit nyo at anong mangyayari sa inyo sa sakit nyo. So, we have been trained, specially trained in communication skills, especially in the skill of breaking the bad news. So, sa awa ng Diyos, would you believe, wala pa akong pasyenteng na depressed dahil lang sa sinabi ko yung katotohanan ng sakit niya. In fact, nagpapasalamat sila. That's my common experience. No? They thank you a lot for sharing the truth with them.
Thank you very much, Doc. Ang dami naming natutunan. We still have questions. You mentioned about training. Yung mga family members, Doc, like for example, like me, na may inaalagaan din pong family member, no? Is it possible to get the same training that you've had without undergoing through the entire years of medical education that you guys have po as palliative care specialists?
Actually, well, there are no formal family caregiver training in the Philippines. Usually nga, nire-requestan kami ng mga lay forum, lay fora. So, hanggang doon na lang. So, at least for us in palliative care, we invite family members to accompany the patient with every consultation. So, part of our consultation is actually not just to address ourselves to the patient, but also to the family. So, kasama yung pamilya palagi pag nagpapakonsulta. At pag nag-a-admit, syempre. Tapos lahat ng paliwanag namin sa pasyente, pinapaliwanag namin sa family members para we're on the same page. So, tinuturuan namin ng mga basic skills, halimbawa, NGT feeding, wound care, diaper change, yung mga ganyan. So, we try our best to equip the family members with the necessary knowledge and skills on basic caregiving. Pero hindi siya formal training. Parang, as you go along in the care of the sick and the dying.
Guidance and assistance lang din po talaga. We have a question from Ms. Elaika. How can you give a dying loved one hope if there is a thin line between giving hope and giving false hope?
Ang false hope kasi is you tell them something that you and I know will not happen. Halimbawa, sasabihin mo na makakatrabaho pa siya. Eh, hinang-hina na siya, di ba? Hindi na nga makatayo. So, paano naman siya makakatrabaho pa? O kaya naman, sasabihin natin na, hindi, next year, magta-travel tayo. Obviously, hindi na niya kaya. Di ba? So, actually, for us, we also somehow go over the bucket list of the patient. I really ask them, Mami, anong gusto mong gawin? Tapos sabi niya, Dok, papayagan mo ba akong pumunta ng Baguio, kaya pumunta ng Tagaytay, kaya, Dok, pwede ba akong pumunta ng beach? So, syempre, depende dun sa functional status ng pasyente kung realistic ba o hindi realistic. No? So, bibigyan kita ng concrete example. I took care of a pediatric palliative care patient. The patient is only 10 years old. He was dying of cancer, a childhood cancer. They are financially challenged. In fact, they were admitted in the Divine Mercy program of Medical City. That means they are receiving some form of support, parang charity ba from Medical City. No? So, and there are a lot of generous donors who are also helping these kinds of patients. No? So love siya ng maraming donors kasi ang cute-cute ng bata, ang cute-cute ng buong pamilya, mga panganay, tapos maliliit pa rin yung mga kapatid. So, syempre, hindi sila masyadong nakakapunta sa beach. Pero gusto ng bata, pupunta siya sa beach. Dying na siya, di ba? So, ang sa akin ng lahat, Dok, papayagan mo ba siyang pumunta ng beach? Sabi ko, bakit naman hindi? Kahit naman pigilan ko siya, mamamatay pa rin siya kahit na nasa medical city siya, di ba? So, kung gusto ng pasyente natin mag-beach, buti na lang, hindi niya kailangan ng oxygen. Sige lang, punta tayo sa beach. So, Punta sila sa exclusive beach resort pa yun, ha? Ganda-ganda. The patient actually passed away in the arms of his mom on the beach. And the mother and the whole family was just so grateful to the whole team for allowing him to pass that way. So peaceful, so happy na nakuha niya yung gusto niya, na nasa beach siya kahit sa huling sandali. No? So, in other words, hindi siya false hope kasi sa awa ng Diyos, nagawa naman namin ng paraan. No? So, hope, by definition, is to long for something that you know is possible but it is not yet there. And the greatest hope of all is, of course, that we go to heaven. Doable? Definitely. Bakit hindi? God wants all of us to go to heaven. So, may panahon pa naman. So, let's work on our relationship with God para nga makarating tayo sa langit, makapunta tayo sa heaven, to be happy ever after with God and all our loved ones of God ahead of us. So, hindi kailangan mawala ng hope ang kahit sino, kahit na mamamatay na siya. Yun lang na alam mong may naghihintay sa'yo. Hinihintay ka ng mga mahal mo sa buhay. At definitely, hinihintay na tayo ni God. No? So parang, actually, we have to be asking ourselves, bakit ba ang pananaw natin, papahirapan tayo ni God palagi? No? Para bang napakasaklap na mamatay at pumunta ng langit, di ba? Parang that's what we've all been aspiring for, to eventually be happy forever in heaven. So, somebody's waiting for us, and that somebody loves us a lot. So that is not false hope. That is real hope. Maybe our life here on earth is ending, but eternal life is just about to begin. And it's a happy life.
Thank you very much, Doc. Last question. Since you mentioned about advance directive and medyo hindi nga po, sabi nga po, hindi sanay ang mga Pilipino na naghahabilin, kumbaga. What is the standard protocol na pina-follow ng hospital or ng doctors, and what can the family do about it?
Actually, in the hospital where I work at the medical city, we have official advance directives. It's already an official form, and practically all the doctors know about it. Even the clerks, the interns, the residents, the fellows, and the consultants know about it. And we are making it the most ordinary thing in the world to be discussing advance directives with our patients and their families. No? And how do I introduce the topic? So you start with the diagnosis. Kaya importante in the first place, alam ng pasyente ang diagnosis niya. Kasi kung di niya alam yung diagnosis, paano tayo mag-advance directives, di ba? Kung di niya alam na may cancer siya, hindi niya alam na stage 4 cancer siya, hindi niya alam na dying na pala siya, o paano tayo mag-advance directives, di ba? So normally, halimbawa, maaga-aga pa, then we say, Mami, lahat ng bagay maganda, naghahanda. Kasi mahirap yung nagugulantang na lang tayo, hindi natin alam yung gagawin natin. Eh syempre, ako, doktor mo, dapat alam ko lahat ng gusto mo kasi para maalagaan kita, based on yung sa gusto mo, hindi ko gagawin yung ayaw mo. Kaya ikaw, sabihin mo nga sa akin, pag nahihirapan kang huminga, gusto mo ba yung tutubuhan ka namin at ikakabit ka namin sa respirator? Yung pinapasok, napapaliwanag ko, paano yung proseso, ganyan. Sabi, ay naku, Dok, huwag mong gagawin sa akin yan, masakit ba yan? Sabi ko, ay syempre po, masakit kasi papasok sa lalamunan, mahaba yung tubo, matigas. So, ay naku, Dok, ayoko niyan. Tapos ayoko ng mga artificial na mechanical ventilator, ayoko niyan. O kaya naman sabihin niya, Dok, huwag mo akong bubutasan mo ako dito, bubutasan mo ako sa tiyan ko, lahat binutasan mo na, ayoko niyan. So, if you make it as the most normal thing to talk about, patients are actually encouraged to tell us what they want and don't want. So don't make such a melodramatic thing about it, no? So parang ang lagi kong tinuturo sa residente at saka sa fellows, huwag niyo tatanungin sa pasyente na, Mami, ikaw ba nahihirapan? Gusto mo tulungan ka namin huminga? Siyempre sasabihin ko sa kanila, ikaw ba naman, ang pasyente, siyempre, sagot mo, natural, tulungan mo ako huminga. Pero hindi mo naman pinaliwanag na yung pagtulong pala sa paghinga, itutubuhan mo siya at kakabit mo siya sa mechanical ventilator. So, hindi ganun yung pagtatanong. Ang tamang pagtatanong is, pag nahirapan po kayong huminga, may mga pamamaraan po kami para matulungan kayong makahinga. So definitely po, hindi namin kayo pababayaang mahirapang huminga. So lalagyan namin kayo ng nasal cannula, face mask, so iba pa. Marami pa kasing ways of giving oxygen bago yung actual intubation and mechanical ventilator. So we walk them through the process of giving oxygenation at the end of life. So hindi sila nagugulat, hindi sila na-horrify when actually pinili nila yon. No? So yun din, pati CPR, paano ginagawa ang CPR, no, cardiopulmonary resuscitation, yun.
Thank you very much, ma'am. We have one last question from Facebook from Miss Alma Viray. She says, this is my first time to hear about palliative care. Is majority of the hospitals do offer palliative care? If not, why?
This is a very sad thing that not all hospitals have the palliative care service. In fact, there are very few of us specialists in palliative care. Some people may have gone through some short training, observership, even conferences. Pero yung what we call fellowship training in palliative care na we went through specialization, subspecialization, there are about 50 of us in the whole Philippines. And some of us are in major hospitals in the country. Here in Metro Manila, maybe there are not even 10 hospitals, 10 major hospitals who have palliative care. And the reason being, because we're few to begin with. Kami, konti lang kami. At konti lang ang doktor na gustong mag-subspecialization in palliative care. Ang number one tanong nila sa akin is, Doc, hindi ka ba nadidepress sa specialization mo? Paano mo natitake yan, Doc? Ganyan. Nakakalungkot naman, Doc. Ang morbid naman ng field mo, Doc. Tapos ang lagi ko lang sinasabi sa kanila, well, for me, it's not morbid. It's not draining. It's not depressing. In fact, it's very, very fulfilling. Because the one that made me go to this field is because I don't like it when the patients are suffering so much and the doctors are not doing anything about it. Binabaliwala lang nila ang pain and suffering ng mga pasyente. And I felt like that should not be the case. They should be as pain-free and as peaceful as possible all the way to death. And that's why I took it upon myself to train in supporting palliative and hospice care. And the first training was actually in PGH. Up to now, PGH is still the place to go when it comes to fellowship training. But luckily, other hospitals are starting their fellowship training in supportive hospice and palliative care.
That's it. Thank you. Thank you, Dr. Maria Fidelis Manalo. I'm sure our audience learned a lot from you. Thank you for your very informative presentation and for your time to join us today.
Sure.
To all of you who joined us today, thank you for watching. Once again, thank you to Vernu, our official event partner for the 2020 St. Peter DeathCare Week. And of course, to Mr. Brian Silato of 360 Next, thank you for our wonderful creatives. We still have more activities in the next couple of days. Tomorrow at 2 p.m., we will have Miss Vina Cruz of Fashionista Camp Asia for a grief recovery session. On October 30, also at 2 p.m., we will have a panel of experts discuss the importance of memorial pre-planning. Then on October 31, 2 p.m., we will talk about the lives of 3 death care service professionals. Very interesting. And then on November 1, we will have our Gintong Alaala Holy Mass. It's a Catholic Eucharistic celebration. So if you have prayer intentions, you may leave us a message so that we can include them during the Holy Mass. And on November 2, All Souls Day, we will be having an hour of praise and worship in Thanksgiving and celebration of life from 8 o'clock to 9 o'clock, also here in our Facebook page. All of these activities will be broadcasted live here in the official St. Peter Life Plan and Chapel's Facebook page. So please join us as we commemorate the memories of our departed loved ones this and that. So this is your host, Rona Lucas Kiansha, now signing off. Thank you very much and God bless.